I'm really grateful that I've been invited to share some up-to-date information. I think it's relevant to some of our parents and adult users here, and also to professionals. And this is to share what is forthcoming. It's about to come online during this year. New international evidence-based clinical practice guidelines for screening, assessment, diagnosis and classification of cerebral visual impairment. And I'm just going to introduce you to the guidelines. I spoke this morning a little bit about brain-based vision disorders, and it is a very wide area, from severe loss of basic vision or clarity of visual image to higher order visual perceptual disorders. It's a very complex and diverse condition, and internationally, including in the United Kingdom, we haven't had any consensus guidelines. So it is very piecemeal in this country. Who assesses cerebral visual impairment, what kind of methods they're using, and in particular reaching decisions on diagnosis, which in some cases is clear-cut, but it is a very fuzzy area. It's much, much more difficult than measuring vision loss when it comes from an eye disorder. So we've had limited consensus, we've had poor assessment methodology, and there is a risk that it's either under or misdiagnosed. And I have a hunch that we are probably underdiagnosing in the brain pediatric tumour population. So just to tell you what it is, it's coming online. We have told you what it's covering, and it will be leading, we hope, to better assessment methods and formulation and more accurate diagnoses. And it should be a lot less confusing and frustrating for parents and young users. You're probably here not overlapping with a parent-based and user-based society I have a lot of contact with, which is called the CVI Society in England, but I can share that there is huge frustration across the country, and there is a lot of disagreement between professionals themselves about whether a child has a CVI or not. And our project, and I'll tell you more obviously about it, started in 2020, and we're now 2026, and we're a group of colleagues who are leading in both research and clinical practice in this area internationally. We've had a lot of discussions, and in fact, even at the last moment, it has felt at times that we might fall apart. So even with a group who work together very, very closely, we meet once a month online, there's still been huge challenges, and we won't answer everything. But Great Ormond Street has played a very big role in it, so my time there. We as a group were commissioned by the European Academy for Childhood Onset Disability, who funded the project. It was based in terms of fund holding at Great Ormond Street Hospital, where I was the PI on the project. And we're using what's seen as standard good practice when you're building up clinical practice guidelines. You work a lot from the literature that's available. You do what we call a systematic review. It's a very standard procedures. You do a lot of what we call critical appraisal of the research. That was in itself quite challenging because all of us had done the research, quite a lot of it, and there's nothing worse, I have to say, than your fellow peers criticising each other, and you're not allowed to critically appraise your own research. That is a very, very sensitive experience, one that I'm still trying to recover from. And the evidence-based synthesis put together then leads to what we call graded recommendations. So I'm not going to go into the detail of it, it's all going to be published, but I'm going to just show you how we just brought it together. We started, which is good practice, internationally. We went to clinicians. We did it through various international conferences to ask them, what do you need to know in your practice? Very high up was, do we need an operational clinical functional definition? We didn't have consensus about what is CVI. this cerebral visual impairment, what should be the core assessment approach for identification and diagnosis. And a very key thing, and I've heard it said today at different times, we've been talking about intellectual disability, autism, which I could say a lot about, but I haven't today. But when you're picking these areas up, the way they present overlap often with other neurodevelopmental disorders. So a big issue is what we call differential diagnosis. And that in itself is quite tricky, because if one thinks of children with perhaps more severe autism, they may have quite avoidant behaviours in what they look at. So you could, through the ophthalmologist's experience, think that child can't see something, and yet something else that might motivate them more, they may actually see, quite small, at distance. You then got a lot of dilemmas. So we use this model, it's called evidence-based practice methods, and so you're working from, we also went to parents and adult users with CVI, and then pulled it all together, and it's led to, and we've been working incredibly hard to slow the systematic review process, took a very long time to do it, and we really had to do it ourselves. It's the level of knowledge required. We couldn't really put it to a research assistant, though we had research assistants working with us. So we've got 11 clinical practice guidelines, and I haven't gone through all of them today, but they cover these different areas. I'm just going to start with a key one, is that we will now have for the first time a clinical consensus definition that's come out of the literature. A very big one, and this is really a bit of a key take-home message to all of you, is that the argument that's gone on and continues to go on across the world is, firstly, is this the area that just ophthalmologists and opticians deal with, or do paediatric neurodisability teams also deal with it? And the important reason for that is that ophthalmologists and their teams, which is optometrists and orthoptists, all the ones in their multidisciplinary team, are expert at measuring what we call lower order vision. That's clarity of visual image, what you have when you go to the optician. We use things called contrast sensitivity, we measure field, we look at things to do with what we call the neuro-ophthalmological disorders, the eyes themselves, the eye movements, squints. So in various parts of the world, the ophthalmologist will either say it's my area of work, or in quite a lot of countries in Europe where I meet ophthalmologists, they say it's nothing to do with me. Anything that's going on in the brain is to do with paediatric neurologists. Paediatric neurologist says, I'm not trained to look at this kind of vision level. Some have, and Great Ormond Street, we have neurodisability pediatricians who can measure vision, but that is a very small group. So you've already got that disagreement, and then we've added in, so we're saying that CVI is a spectrum of disorders of lower order vision functions and or. I can't tell you how much discussion there's been on the word and or. And we're talking multicultural, we're an international group, but that's led to a lot. And I often, when I'm typing up, I seem to forget the oblique line. Anyway, and or higher order visual functions. That is the visual perceptual. Again, some ophthalmologists say, well, if it's visual perceptions, it's not CVI. And that for a long time was the American position. It's now changing. Anyway, we've now got these disorders of lower and or higher order visual perceptual functions. Visual perception, I could be giving a whole talk on it, and I haven't even brought any pictures about it, but visual perception is all your interpretation of what you're looking at. So if you're looking at a square and a circle and a rectangle, your brain can tell you immediately, without touching it, what the shape is. That is your visual perception. It's working hard to differentiate the different images. In fact, vision involves perception. You don't have really much vision. You have a bit, but it's not very meaningful. You can light contrast or colour contrast without a lot of perception. So we've also said it's associated with limitations of everyday vision-related activities. So we tend to think if you've got a disorder of this kind, it will affect you in your everyday life. Now, you may not know that you've got a problem because your child, or if you're an adult user, you may go backwards and forwards. You think something's not going well with your vision, but you go to your ophthalmologist or your optician, and they may measure, and I know I've met quite a few people here over the years who say, when I go to the ophthalmologist, oh goodness, I got to leave it quicker. See, I get carried away. This is a terrible problem. It's getting worse as I go to timekeeping is even worse. Anyway, it's always weak. So I'm going to go very quickly. The key things are those signs of clarity vision, restriction of visual fields, abnormal supranuclear eye movements, and or difficulties in higher processing, including perception and interpretation of visual imagery. So we've got this new definition, and an important thing in our second clinical practice guideline, when we go through, the whole team agreed when we went through the populations at risk, we were going to include brain tumour. And brain tumour is there because it is an at-risk population. You're going to be named as that, and that will be very, very important. So these are what it covers. It's very, very detailed guidance. It will go through each stage of what the literature is showing. There's a lot of areas that we need new research. There's still a lot to be found out. We don't know a great deal about the higher order visual perceptual difficulties around the different brain tumour difficulties. And neuropsychologists have played a very big role and are seen as a very key group. So just to be showing, in addition to when we're starting to work towards training, once the guidelines come out, they will cover the assessment, they will cover what the ophthalmologist needs to do, what the neurodisability team need to do. Neuropsychology and neurodisability paediatricians are very key in this, and occupational therapists as well, working together. So it's very much seen as a joint group, and we've got a very clear, when we train on it, we're already showing what comes from this, is that you can see two specialties have to come together, and as they're working together, you're working on the ways that you can identify what's happening, the kind of tests that need to be going on. And we have very much pushed for standardized, verifiable, systematic, but also scientifically developed assessment tools that always have to be interpreted within the child's developmental context. So really just a final endpoint is that we hope this is going to improve. It won't answer all our questions because we still haven't got the research on what we call diagnostic accuracy, and we haven't got the research on what's called screening accuracy. But it is going to lead to a lot more harmonisation. It is international, so it will be coming on board. We hope the UK will, that a lot of colleagues will want to have the training in it. And it will mean that I think for families with children with brain tumours and for adults, they will have, I think, the right or the opportunity to request that they have a proper assessment in CVI in terms of their future. So we hope it will lead to better access and support, because if you don't have the original assessment and diagnosis, it's very difficult to get the appropriate access to support and consistency of care. So we're publishing this summer, and this is just a thank you to the key colleagues involved and our funding and university and trust hospitals internationally who are supporting us. So thank you very much.